Pleasure for me to be here today, and thank the organizers for inviting me. I almost feel like we need to be in kind of an AA meeting and kind of say, yes, I am a DCB user. It's interesting time, great discussion. So the topic I'm talking on today is role of debulking, lumen gain, or more than that, my disclosures. So as you've just heard, we have many options in this time for treatment of our patients with lower extremity vascular disease. We have PTA, we have stenting, specialty stents, specialty balloons, drug-eluting balloons, drug-eluting stents, atherectomies, and all sorts of combinations of all of those. All of those result in lumen gain, at least initially. And lumen gain is important. As the radius of the vessel improves, the flow through the vessel doesn't increase linearly. It goes up by a power of 4. That's important not just for claudicants, but especially important for patients with critical ischemia, where supply of oxygenated blood is important and essential for wound healing. Diving into the modalities a little bit, angioplasty does give you lumen gain, but usually short-lived. There's elastic recoil. There could be dissection. The combination of recoil and dissection will lead to a suboptimal outcome in terms of what we've become used to now in this day and age, not what we were doing 15 or 20 years ago. And so I think this is really, in most cases, the type of patients we treat on a real-world basis, not doable. Stenting is definitely a lot better than angioplasty alone, but as the duration of follow-up goes longer and as the lesion lengths become longer, even stenting with bare metal stents becomes somewhat suboptimal. With the Zilver stent, drug-eluting stent, the first one which was out, good results for short lesions, but as lesions become longer, duration becomes 24, 36 months, outcomes again become somewhat problematic. With Eluvia, we don't have data for long lesions out more than 2 years, and so we wait that. Maybe that'll be better with a longer-term paclitaxel duration. Drug-coated balloons really were a revolution, as you just heard, with paclitaxel gate. Let's see what happens with that as new data comes out. But they are an improvement as compared to angioplasty alone. But as you go from randomized trials to real-world registries, longer lesions, more complex lesions, the risk of bailout stenting goes up to the 40 to 45% rate. So that brings in atherectomy. Is there a role for atherectomy for debulking beyond just lumen gain? There are many types of atherectomy devices: directional, rotational, orbital, atheroablative, or laser, helical. And there's many benefits. There's plaque calcium, and in some cases thrombus removal. This allows for plaque modification, allows for lumen gain and improved minimal luminal diameter. And for those of us from cardiology, MLD is king. And selective treatment of diseased tissue, and I'll get to that in a little bit more in a couple of slides, about the importance potentially of treating only diseased tissue and leaving healthy tissue aside. And as a result of these attributes, you have reduced risk of dissection, reduced need for bailout stenting, enabling this leave nothing behind strategy, if you're a believer in that, allows for treatment of no stent zones, a common femoral artery and the popliteal artery, a better long-term efficacy as compared to PTA alone, probably because of the ability to treat diseased tissue and leave healthy tissue alone, and probably also increased efficacy of drug delivery devices. What are the data for atherectomy and debulking of the FEMPOP segment? This is the combined literature set we have for the FEMPOP segment in terms of published trials, looking at directional atherectomy, orbital atherectomy, rotational atherectomy, and laser. The largest of these trials was 800 patients, directional atherectomy. This was several years ago. All the other trials that have been published are significantly smaller than 800 patients. But there's interesting patterns that emerge as you start looking into these data. And one of the patterns that emerges is that as you go from short lesions to more complex, longer, and calcified lesions with atherectomy, you find that the expected drop-off in patency isn't as much as you would expect. For example, in this claudicant population in directional and definitive LE for directional atherectomy at 12 months, for mean lesion lengths of 6.5 centimeters, you have a patency of 83%, no DCB here. But as you increase to a mean lesion length of 14.4 centimeters, there is a drop-off in patency, but not as much as you would expect. Similarly, as complexity goes up from task A to task C, and lesion length goes up from 4.6 centimeters to 16.5 centimeters mean lesion length, there's a drop in patency, but not as much as you would expect, from 81% down to 72%. As you go from the FEMPOP segment to the infrapopliteal segment, similarly, there's equal or even better, potentially, patency at 1 year, with a 90% patency among claudicants in the infrapopliteal segment with a mean lesion length of 5.5 centimeters. So something is going on here. Similarly with diabetics, no difference with directional atherectomy in diabetics versus non-diabetics in the FEMPOP segment. Looking at rotational atherectomy here, this is the JET registry. This is not published but has been presented. 241 patients, 258 lesions, mean lesion length of 16.4 centimeters, 50% of which had grade 3 or grade 4 calcification. 77% patency at 12 months without any drug-coated technology, atherectomy alone, again, 16.4 centimeter mean lesion length. So what is going on here? We're not quite sure. There is a hypothesis out of a data set that came out of Mount Sinai in which 116 patients were treated with directional atherectomy and followed out to 1 year for patency. The mean patency or restenosis was 56% at 1 year. But the debris or the atheroma, which was collected, was analyzed for adventitial elements. And among those patients in whom there were adventitial elements in the atheroma, the patency was very low, 11%. And among those in whom there was no adventitial elements at 1 year, the patency was 97%. Interesting, small data set, but hypothesis generating that maybe if you don't cross the external elastic lamina and you treat only the healthy tissue, then you reduce the amount of inflammatory response and therefore the patency becomes higher. So that may be one of the reasons that we see good results with atherectomy comparable to stents, but better than angioplasty alone. What about atherectomy plus DCB? Here's number 2 times in 1 hour that this same slide has been shown, as you had seen earlier. As calcium increases, it appears that drug delivery to the media and adventitia goes down. If you treat in a cadaveric model tibial vessels with orbital atherectomy, it does appear that paclitaxel goes deeper. As a result, it appears that atherectomy to remove calcium does improve drug delivery. This has been looked at in a few trials that are mostly single center, only one randomized trial, the definitive AR, again several years old now. But this did show that among certain populations, those patients with long lesions, more than 10 centimeters, and those with severe calcification, that there's a trend towards a benefit of atherectomy first before drug-coated balloons. This was a small study with 120 patients, therefore hypothesis generating only. But another interesting thing here was that optimal atherectomy, as defined by less than 30% visual residual before DCB, resulted in much better outcomes angiographically at 1 year as compared to suboptimal atherectomy followed by DCB, suboptimal defined by greater than 30% visual. So what about disadvantages? These are expensive devices, so therefore definitely adds to the cost of the procedure. There is almost uniformly a need for embolic protection. I almost always use this insurance policy of embolic protection, therefore extra cost. There is a learning curve and the procedures are longer and more complex. But if you want to treat heavily calcified FemPop segments with good results without the need for stenting, you need to remove the plaque, you need to modify the lesion, and then you can get good results as well. And these results are usually sustainable out to 12 months. And so in conclusion, short-term lumen gain is possible with all modalities, including atherectomy, but debulking with atherectomy also decreases the risk of recoil, dissection, bailout stenting, especially in calcified lesions. It allows the treatment of no stent zones and enables a no stent, leave nothing behind strategy. Allows for the treatment of diseased tissue selectively, and this probably reduces new intramural hyperplasia and restenosis risk, and it does appear to increase drug delivery. But it is more expensive, usually requires embolic protection, and there is a learning curve. So atherectomy first may be a good option for complex disease, but we don't have enough data. We need larger, longer sets of data, and preferably randomized. Thank you.
Thank you, Rob.